All right, so it is 4 after. We'll go ahead and jump in and get started. Welcome everybody to our coffee chat today on outcomes in medical respite. It's been a while since we've had a coffee chat, so I'm just going to remind folks of what the format for today looks like, because it is definitely a little bit different than some of the webinars that we've hosted in the past year or so. So coffee chat is really informal. It is an opportunity for us to learn and share from each other. Many of us are with medical respite programs that you're the only respite program in your community, in some cases the only one in your state potentially, and so sometimes that can feel very lonely and isolating. So coffee chats are an opportunity for us all really to come together and have conversations and learn from each other. So I resisted the urge to do any PowerPoint slides at all, which if any of you have attended something that I've facilitated is a really big personal growth step for me, because really I want us to have opportunity to converse sort of face to face. So if you're comfortable with turning off your camera, just so we can sort of have more of a group format, I definitely welcome that. But we welcome participation in whatever way that you're comfortable. Please feel free to raise hand if you're not really comfortable interjecting. We'll also be monitoring the chat to bring up questions for each other, and I'll be happy to facilitate that conversation. I'm also really excited we have Susanna King and Lori Nelson here, who are sort of prepared to share their experiences as well, but I really welcome questions and suggestions from everyone. So great to have you all here today. I didn't do a PowerPoint, but I am going to start with a Mentimeter, which is not a PowerPoint because it's much more interactive than that. So for folks who haven't used Mentimeter before, it's really a way for us to sort of share with each other and kind of see where some similarities and differences are. So you can access the Mentimeter poll in any number of ways. You can go to menti.com and use the code that's on the screen here, 72643526, or if you're really tech savvy, you can scan using your phone for the QR code, and that will take you from your screen to the Mentimeter as well. So I'm going to give folks just a moment to get logged into the Menti, and we're going to start just with a few questions of sort of ground building, I think, of where we all are and in this outcomes process, and where we're comfortable fitting in. Excellent. I see people joining. Fantastic. So I'm going to start, well, I'll leave this up for one more minute just to give folks a chance to log in here, in case you're QR code savvy. So I'm going to move to our first question, but if you need the link or the code, they are in the chat. You can access the Mentimeter poll that way. So first and foremost, just getting a sense of who's in the room here, of what your role is within the medical respite program. So this is much more fun than a PowerPoint. Awesome. So we have quite a mix of folks here, almost not totally even, but pretty even distribution of people with different roles in the respite program. And I can't remember if I let you pick more than one answer, so people might be serving in dual roles as well. So this is really great to see kind of some different perspectives here. So our next question here is really just about what your program is currently doing in regards to data. Depending on how new your program is, you might be in a different spot. And sometimes if you've been in progress for a while, you haven't really thought about data and outcomes. So curious to see where folks are at. And some of you might know, might not know, depending on the position that you're in your facility. Great. So again, seems like people are really kind of at the beginning stages or thinking about how to improve, which is excellent. You are in the right place, because hopefully coming away from today's conversations, you'll have some new ideas about really where you want to go with data and outcomes in your program. So the next question here, just sort of the role that you'll play in collecting data and outcomes, and seeing what's going to be your part in overseeing how these are measured. Lots of data folks here. For the person who entered, I hope not. What I will say, I was sharing this with Julia earlier, is that I was an outcome adverse person many years ago. I don't identify as a numbers person, and kind of my resistance or fear of it has transitioned me into someone who likes talking about that. So maybe that will be the outcome of today's conversation. But if not, I know there's plenty of numbers people who are always happy to support those of us that aren't. So. Great. All right, kind of a mix here. And then thinking about the different types of outcomes that we could potentially track in medical respite, these are some really big, thanks, Julia. So these are some really big buckets of types of outcomes that we could be tracking. So just curious as to where folks think these buckets fall in terms of importance, and looking at these in the respite program. I'm not surprised that most of these fell into some level of importance. I think as respite providers, we like to think that all things are important here, but I do appreciate sort of that shift in that focus and emphasis on some things outside of cost savings, and not to say that that's not necessarily important, but really helping us focus on those health and social outcomes, which again, we're going to talk a little bit more about today. I think, yes, this is our last question here. So just in sort of to get us started in terms of our conversation together, what are you tracking? So we have those big buckets: health, social, program, outcomes, cost savings, but we'd like to provide a little bit more specific detail. Be interested in seeing what that is, and other, because there were a few of those as well. So we have demographics, length of stay, disposition, the referral source. Great. Length of stay by discharging condition. Ooh, that's an interesting one. Yeah, I bet you get some strong differences depending. Where the guest exits to, absolutely. Bit of a mix in terms of readmission rate, ER utilization, length of stay, costs, social outcomes, personal health literacy. That's a great one. Income and stability, referrals while in respite, conditions, goals. Length of stay seems to be a really popular one to track. Discharge location. And for those of you who are tracking it, one of the things we can maybe talk about is sort of how you use that information regarding length of stay. This is great. I'll leave this up for a couple more minutes. And what I will note is that we are actually able to save the poll results from doing this. So if you're hurriedly kind of scratching down ideas, we can certainly sort of send out a summary after today's session too for folks. Patient satisfaction, excellent. I think that's the first time that's come up. That's a great one, especially through consumer surveys and interviews. Satisfaction with experience is wonderful. Great connection to services, what referrals are denied, I think can be another really important outcome. Excellent. All right, so I'm going to stop share now. Thank you everybody for participating and sort of giving us an idea of where we are and what we are doing. So now is the exciting time where we really get to sort of open up for discussion. So I'm going to start us off with a question here, but folks, please feel free to add in your own questions, again, in the chat and for each other throughout today's conversation. So I'm going to go back to those big buckets of outcomes that we talked about. And what I'm going to state is that we did a literature review last year, and a lot of the outcomes that have been published in research are really focused on that cost savings piece. What was notable to me is that that wasn't rated as most important by many of you during the survey. And part of the reason I think for that is that it can be really hard for sort of an independent respite program to be able to access that information and track it and demonstrate it, especially for these much larger systems. So I'm curious, the question I'm going to open up to you all, and perhaps Lori or Susanna, you want to jump in first, what are some of the outcomes your program tracks that you can look at internally, where you sort of have control over the data and can really look at those outcomes? I'm going to throw the question in the chat as well.
So we've come a long way with outcomes and kind of how they've evolved from in the 8 years that I've been with the agency, because I would say when I started, we were doing a lot of demographic tracking. So there's value in knowing the difference between the two and but then also what your referral providers are actually looking for. So, where we were really focused on the cost savings and what we would, we were really focused on cost of bed night and how that translates into what it would save the hospitals. And we were really shut down at that point. So we really did shift, and we look more at, and it's ever evolving. While that makes it a little more difficult, I think it's necessary because your community is going to look different all the time, and your hospital needs or what they want to see change is going to change all the time. So you have to be responsive to that. What we track internally, we've really pushed, and I wrote the personal health literacy, because that is what we're finding is of most value to the hospitals. And what it translates into is a better patient for them in the future, and also a reduction in recidivism that they can track easily. So somebody who they've referred, one of the 5 systems in Cincinnati, they can easily see if someone does not return. Now, it's kind of a negative outcome because it could mean they're just not in the community anymore, or it doesn't necessarily mean they're not utilizing that resource. They're just not utilizing the resource there. But that's what the hospital cares about. But for our part, and what we're doing internally really is taking the time within case management to spend time with that client to make sure establishing benefits, which is going to be like sort of your emergent case management piece. But then also helping them understand what it means and getting comfortable with it. So walking through with them on how to utilize their Medicaid, what their benefits are, and how to utilize them. So, you need transportation to this or this provider. Okay, let's sit down together and we're going to call and we're going to set this up because it is part of your benefit plan. That's just an example. I mean, it's going to be different with every provider in every community, but it's getting the client comfortable with utilizing those benefits, having them do as much of it on their own as possible to increase their literacy. So if they are utilizing the emergency room, they can go in and say, hey, I have this benefit. I know this and this about my benefit. and it makes them a better consumer at the hospital level. And that's kind of what we're pushing externally, what we're pushing out to our partners, our hospitals and other providers, that we're spending the time to educate the client. Now we are tracking that internally. So we're, we have an individualized case plan. Personal health literacy is always a goal. And, we're tracking, do they know who their provider is? Do they know how to access their benefits? Do they know how to contact their provider? Those are very easy things that we're tracking within case notes. And it's easy to pull that out on the backside because, we use it in a drop-down box and pull that information. And that's great information to provide to their original referral source when we're reporting back.
Great, thanks, Lori.
Yeah, I just want to echo some of the things that Laurel had mentioned, that we have been, our program has been a bit disrupted and shifted during COVID, as I'm sure many of yours have. And we are now looking at doing a lot of planning toward our new respite program that'll be starting hopefully spring, summer of 2022. So we've started to think through what kind of data would be helpful to collect and what do we want to be looking at. So this is a timely conversation. I think historically we have done a lot of tracking of referral and care outcomes. So for example, percentage of people who have established a PCP or attended specialty cares while they were having a respite admission, getting people connected to mental health and substance use disorder services, and then doing the teaching piece, teaching people how to use their benefits, teaching people how to take their medication, how to make appointments, like just doing that really, taking the stay in respite as a time for really digging in with people and taking the time to provide that one-to-one care that would be helpful as they transition out of respite and into whatever situation that they're going into next. We also track that data too, where people, if we can, where people are going after they discharge from respite, including if they, ended up with ED visits or hospital readmission, and really looking in the future of how to track some patient-centered goals, but also how are we providing care in a holistic way in partnership with the patient, and how can we track that data and how can we capture it in a way that is telling us if we're providing equitable services or if we, have areas that we can improve upon, and how can we provide a better quality of care?
So great questions. And I like sort of how both of you that internal focus is on, some of things that are kind of qualitative and quantitative, right? So you can look at percentage of things, but then also digging into time spent teaching. And I really love sort of that health literacy, health management piece of it, because that's such a critical piece of respite. So I'll open this question up to others that may want to share, or maybe who have some follow-up questions for Susanna and Lori.
Yeah, I can go. So my name's Kyle Lowe. I work for a managed care organization based in the Midwest. So we're the payer. And so I think where we have an excellent ability is healthcare utilization, cost savings, longer term health outcomes. Even after their discharge from respite, we still have the ability to track. I think that's where we do a great job, and we can be a good partner with respite to show those outcomes longer term that they might not have access to. Where we have a weakness is the ability to track those social, or some like to call it soft, but I don't believe that. Kind of softer outcomes like housing, employment, or as you said, health literacy. And I think where we run into an issue is that as we scale respite programs, so as we have members in 10 or 12 respite facilities around states or around a region, every respite has its own systems of tracking or surveying their members. And so when we're trying to analyze it, or trying to show data sets or justify cost to leaders or things like that, it can be a pretty big mountain to climb to aggregate all that data from 10 different respite facilities using 10 different methods to survey their members or residents. So I just wanted to offer that perspective.
That's a helpful perspective. And Kyle, I'll ask a question I think that will help us and maybe some other folks in the room is sort of any suggestions. I think one barrier that programs really have is getting connected with the person in the health plan that can talk about collecting this data or collaborating with that, with the payers around data collection. Any tips for kind of starting off that conversation and working together to look at that data?
I think that, one of the silver linings of the pandemic is it's really exacerbated the housing crisis, and Medicaid payers are very much starting to take notice, and they're starting to devote resources and staff to these issues. Perfect example is, my own role. I'm the first person in this role focused on housing for our markets. So I think that if you haven't reached out or haven't talked to your payers in a while, they don't know what they don't know. There's so many things that we manage or look at. This is one program of 15 that I'm looking at. So when they reach out to us or when they want to offer partnerships, want to offer ways to track, I think that's great. The more that you can kind of bring to the table, like, hey, this is what we're interested in. This is what our gaps are. Is there any way we can partner or help on this? Pie in the sky wish would be, if you have a bunch of respite facilities in one state, is there a way to standardize how we measure or track those social outcomes? So then all the payers are able to easily integrate that data.
Great. Thanks. That's helpful. And I think, sometimes it's, from the respite provider and just a matter of finding the right person in the, in the NCO, for example, or the ACO, just that is doing that particular role. Sometimes that can be the hard nut to crack. But I appreciate that sort of, I think the balance of the respite program being able to bring forward, here's the data that we're collecting, that we're tracking, that we can offer you sort of in return, and, coming at it as a partnership, as opposed to sort of relying on the plan to do all of the data collection and maybe filling in some of those gaps or weaknesses, as you mentioned too.
Yeah, and I mean, a great place to always start is just your provider relations rep. That's probably the easiest point of entry to deal with most of the Medicaid plans, because I agree, it can be very labyrinthine, and there's a lot of turnover that happens in our plans too. So who you're talking to one month might not be the same 6 months later, but the provider relations is usually a good route to go.
Thanks, Kyle. And a question, Lori, in the chat was, do you have a personal health literacy assessment tool that you use specifically?
So not currently. I think assessing that would be difficult. Although I don't think impossible, because, as I sit here and think about it, because it really is individualized. So, we're doing a social needs assessment at the beginning, and we're looking at things like basic literacy and competency. So every person is going to be coming to that with a different level of ability to manage. So I think a general assessment of just that piece would be very challenging. I wouldn't say impossible, but I think we're really looking at it from the lens of the client being how much they can manage on their own and kind of meeting them where they are. So because with everything with our clients, based on their general literacy and their general competency to manage, we're adjusting our case management to that. So I don't think it's impossible, but it's not anything we have right now because it's so individualized.
And Lori, if I can, or Laurel, if I can just jump in. This is Sarah Juvenju from the Santa Clara Respite. I was just really interested in how you framed it though, where it looks like you're looking at kind of certain benchmarks for kind of basic literacy around navigating the healthcare system. So like how to make an appointment, how to schedule transportation. Do you have a list of those like specific kind of things that you're working on, that you like goals that clients who come to respite, or skills, I guess, that clients that come to respite are able to leave with?
And once again, that's really individualized. Yeah. We end up aggregating the data, but it takes a lot of us looking at it. So we don't have anything, of course, we're a smaller respite, so that makes it a little bit easier because, you know, in any given month, we're looking at maybe 25 people, but we can aggregate that data just by eyesight and saying, okay, this we feel, and a lot of it's based on their case plan in general. So depending on how many goals they have and how many they complete within a case plan kind of determines how we count the success of a case plan. So it's not as, and I mean, if somebody finds it to be easy to create that kind of assessment tool for that, I'd love to know, because I feel like we have to do a lot of manual calculation to determine success. Because you're dealing with such varied individuals, it's hard to capture it in anything that's simple like that. I don't know if that answers the question. It lends itself to a lot of qualitative outcomes for us. I think it's more about the story than a number.
And Kyle shared in the chat the AHRQ. I always forget exactly what that stands for, but they have a fantastic comprehensive set of resources regarding health literacy. If that's something your program isn't sort of intentionally addressing at this point in time, or you want to learn more about it, they have a lot of information in there, both regarding some survey tools, that a couple of them that I've used in the past, as well as just some resources about how to make your program or organization more accessible for different levels of health literacy. So it's a great tool and resource, and it's also one you could potentially recommend to partners who maybe don't provide the best, most health literate types of care. This is a great sort of neutral resource that you can point folks to as well. But I've used a lot of their resources from there. Thanks for sharing that, Kyle, because it is really fantastic. And there may be a few assessment tools to look at that might be applicable within the respite setting that could give a little bit more of that quantitative measurement that you're talking about.
We also have a sample tool that we used in a project a few years ago around self-management. And this is, again, very individualized, but it asks questions just around, like, for the first 15 days, this is my goal, and these are the steps I will take to achieve it. And this is what could make achieving that goal difficult. My plans for overcoming that, the support I'll need, and then rating the confidence level. Again, that's hard to fit into data specifically. That is more of a narrative piece, but maybe in a follow-up email to everybody who registered, we can include this sample tool. Not exactly health literacy, but more around self-management support.
Thanks, Julia. Yeah, and there's one that's escaping me. I think that has at least been used or is recommended for use with people experiencing homelessness, which is always sort of that differentiating factor, I think, for our population of folks that we're working with, that not all tools are necessarily appropriate for the context that folks are living in. So yeah, similar to that, I will do some digging to see if I can find that resource and share that out as well for attendees, just to kind of see if there's something that might fit. Oh, and Kyle, thank you for bringing up that one as well. The Prepare tool, which does a survey of social determinants of health needs. Is this a tool that programs here? Has anyone used this tool specifically in your respite program? I know a lot of health centers use it. Yeah, Julia noted, we've heard that respite programs have used it, perhaps not folks who are in this call today as well. And certainly health centers use that as well, but that can be another good tool. I think if we're thinking about kind of quantifying, as Lori mentioned a lot, and Susanna as well, a lot of what we're doing really is this qualitative work, right? Which makes it so hard to capture. I think that's part of why we kind of keep having these conversations on outcomes, because we're looking at each of these individual people, their individual care plans, and how do you aggregate that to show that success overall as a program. But some of these tools can be helpful clinically in identifying what social service needs might be, and sort of looking at things more in a yes/no format of, did this person come in with this need and did it get met well in the program, and sort of comparing the yes, there's a need to yes, it got met, and sort of identifying, again, quantifying that the care plan was completed. It doesn't go into that level of detail of really what actually happened and the hours of case management and nursing instruction that goes into it. It really slims that down to numbers, but sometimes those numbers are really helpful to demonstrate that bigger picture piece of what the program is doing overall. Anyone else want to share? Oh, go ahead, Julia.
I was just going to say, I think this is one of the real challenges that we have with respite, especially when we're educating community partners or funders about the work of respite, is the amount of time and energy that goes into this case management and health education and nursing support that is really difficult to quantify or to fit in a box to measure. And so I just think that is a constant challenge for respite programs to figure out how to tell that story in a way that is easily digestible and fits into the metrics of what some of their funding partners are really wanting.
Yeah, and can be certainly more challenging depending on the number of clients you see in your respite and their length of stay. But I think also having staff that are dedicated to tracking that. So again, sort of we saw at the beginning, there's a mix of folks here who are here and talking about outcomes. And that might simply be because sometimes the providers are the same people who are responsible for tracking the outcomes and maybe even looking at what the outcomes are. A small program doesn't necessarily have someone dedicated to looking at these things beyond sort of what the basics are. And I think that can also, that capacity challenge can be hard as well. So curious, and kind of leads into the next question then, is, in your programs, who is responsible for collecting the data, evaluating the data? How do you integrate that into your sort of day-to-day processes? And are there any partnerships that have helped be able to do that, even sort of crunching those numbers?
Well, for our program, as far as collecting the data, we've done some templates and flow sheets in our electronic health record to help make the collection of data easier. It's not necessarily the case, of course, so we're hoping to work on a new build through Epic for collecting data as we move forward. But we also have, we're lucky to be part of a larger public health department. And so we're able to access our data gurus, and they're able to pull information from the back end and help make it into reports. But it's still a lot of kind of digging, like chart reviews and digging through the charts and trying to find information, getting that qualitative data as part of what we're hoping to change as we move into our new respite program. I don't know that the timing's going to work out that way. But we can dream about that. And then I think we've also been able to, we have a relationship with Hennepin Healthcare, which is the hospital downtown here in Minneapolis, and have also had some help with their data staff. So it's really, as far as collaboration, it's been really helpful to have multiple partners with the data collection to help make it a little easier.
We primarily utilize our community. It started as our community's HMIS system, which is really through your continuum and really more housing focused. But we're very lucky that the one that we utilize is very customizable in a very simple way. It's customizable. So we've been able to customize it to really track pretty much anything we want, but a lot of health data. So within the HMIS system, it is tracking all the demographic about the client and, their experience of homelessness and their status. So it's even looking at things like at imminent risk or chronically homeless and the details. But then we are able to customize it to go deep and actually have that individualized case plan within there and those goals within there, and then everything that happens. So that tracking happens with our case management team, which is 2.5 people because we're small. And the analyzer of the data used to be me. And so I've recently, in the past 2 years, turned that over to another staff member who pretty much does that exclusively. So she tracks everything. And for those of you who have a state like the state of Ohio, we don't only just track our internal stuff, we're tracking for multiple funders, plus we are licensed by the state of Ohio as an assisted living facility. So we're part of that role also manages all of our licensing regulations and the documentation that goes with that, the updating of different licenses that we have. So it's a very valuable position, but it is the analysis part, and it's to the point where we're reporting monthly to a lot of funders, quarterly to others, and it's all pulled out of that HMIS system. So, that is a great place to start if you haven't been able to establish a tracking mechanism, especially if you have one that's customizable.
Great. Thanks to you both. Yeah, I think you've kind of pointed to being able to not having a respite program, not having to invent your own thing necessarily from the start, but maybe using some of these systems and partnerships already to be able to even start with some of the data. I think we've talked about a lot of sort of different and big buckets of outcomes, but I think one of the important things to remember, right, is especially if you're just starting out, you don't need to start out with 20 different outcomes, right? Maybe start with 3, like one from each bucket that you're going to look at, and being able to build and grow from there as you build and grow capacity. As Lori mentioned, like that position developed over time out of a need and sort of those growing partnerships and reporting mechanisms that needed to be fulfilled. That may not be where your program is now. And so just to make it feasible for what staffing you have, starting with smaller outcomes that you can really that are part of the workflow and are something that you can access more easily, it can be really, really important. And it's still meaningful. Even small chunks of data, I think, are really meaningful to start communicating with others and funders. I'm curious, I'm kind of going back to, oh, sorry, Lori, did you want to add anything?
I was just going to say for anyone who's, at the very beginning, one of the things we ran into and sort of the downward spiral, I guess, when I first started with the center was we were building our outcomes based on what the latest funder wanted. And we kind of had to stop that because we had multiple places that we were tracking, and we were tracking crazy things, and we were building new outcomes all the time because some grant maker would say, well, it'd be really cool to know. And then we would do it, and it was creating a mess. So what we did is we sat down and we crosswalked everything we have. And I think I've talked about this. Some of you are probably hearing this multiple times, but we just looked at everything that we had. We also looked at community benefit plans that our local hospitals had put in place and what was most important to them. And then what we really thought we could do. And then we built a foundational platform of things to track. And we found that the grantors were very happy with those. So, it was no longer the grantor dictating what we should track. It was us offering this platform of things, and they could say, this is very interesting, and we'd like to see how you utilize this funding for those purposes. And then we were already tracking it. So it has totally flipped our whole process and made things much easier on appeasing the funder, I guess is the best way to put it. So anybody who's just starting out, and I saw from the from our little exercise at the beginning that there are some people who don't know where to begin. And I would tell them, begin with your referral sources. Where are your clients coming from? Where are your patients coming from? And what do they care about? Start there. And it can be very simple, but and I'm a numbers geek. I'm terrible about it. I miss analyzing the data. But what you'll find is it will lead to other things that are interesting, and then you'll get a good sense of what would be interesting to your funder, and you'll start tracking more. But start with what's most important to them, because you need them. And you want to prove to them that you're able to meet their needs and improve their situation that they're dealing with.
Thank you, Lori. That is, I think, really helpful advice for a lot of folks here. And I'm also going to link in the chat, just sort of as a follow-up, one of our documents that is fresh off the press. It's just a month old, that sort of goes into and digs into what these outcomes could be and provides some tangible examples. It's not an exhaustive list. I think programs, need to be responsive to their funders and their communities, but can give you an idea of where to start and maybe some to pick from there as well. So throw that out there. One question I do want to sort of come back to is a lot of folks responded that they're tracking length of stay as an outcome. And I'm really curious as how people are using that information, either to report to funders or to sort of inform their programs and services. Kind of how's that outcome help your program, essentially? And this is open to the group, although certainly Susanna and Lori, feel free to jump in if that's one that you're tracking. Or if you don't know yet, how you're hoping to use it as an outcome.
When we originally were diligently tracking that, because it wasn't great, we were utilizing it to report back to the hospitals. This is how many bed nights we provided to the individuals you referred. And while we still provide that information, it's less important than it used to be, because let's face it, it takes as long as it takes. And, while we have a much more pronounced focus on case management, because it is really the thing that's going to make a client successful, if they can and really improve their independence and their literacy and all of those things from case management. When they're independent, it's going to help, but it takes what it takes. If you're dealing with an individual, because, nobody's just coming in, well, maybe they are, with that one thing that you need to resolve medically. They're coming in with one important thing that led to the referral, but there's probably 5 or 6 other things that you're going to address at the same time. And their level of ability to be independent is going to determine how long they're with you. So if we determine that there is an underlying significant substance abuse problem, chances are our recommendation, and hopefully what they'll choose to do, is treatment. And it may take a long time to get to treatment. That's going to create a longer length of stay. So major substance abuse issue is a thing we track, because it may skew the overall length of stay. Also, trying to get a bed in an assisted living facility or a nursing home may skew that length of stay. Pandemic, trying to find an apartment has totally skewed the length of stay, especially early in the pandemic, because nothing was available. We were in gridlock here. We couldn't bring anybody in and we couldn't get anybody out, and we didn't want to because we were afraid of what they would face in the community on their own during the scary, scary early days of the pandemic. Not that they're not scary now, but maybe a little less scary, or I'm used to it. I don't know. So while length of stay is important and we do utilize it in some capacity, it's not as important as how independent and capable someone is when they're no longer needing our services or when they've completed.
Yeah, and it kind of seems maybe not length of stay in isolation. I was really interested by whoever submitted the answer about length of stay by discharging condition. I think that's a really interesting linkage, because I think that's really helpful to communicate with referral sources, with payers, right, with even just program planning about, you know, like you mentioned, Lori, like somebody who needs substance use treatment and a bed in a, you know, a residential substance use treatment program, that is going to likely be a longer length of stay perhaps than somebody who is non-weight bearing for a couple of weeks while a fracture heals. And in that rare case, that's the only thing that the person potentially needs from the respite program. So I do really I'm really interested in that particular outcome linkage for folks.
I think,
Go ahead, Sarah.
I was just gonna, I mean, I think Lori also made the point that length of stay like really relates to the larger context of kind of, you know, what are how committed are respite programs to discharge out of homelessness and to like other transitional housing programs or housing. And so we're part of a bigger system. And so I think length of stay reflects that. And then I would just say for our program, I think we like to use sort of also the spread of length of stay to really, you know, there's kind of our mean length of stay, but when you look at kind of the spread, you can really see the diversity of like those really brief stays when we have someone we're supporting for like 3 days for a colonoscopy, to people who've been receiving chemo, like, you know, palliative chemotherapy for 9 months, that we're continuing to support, to kind of see that there's just all like such a broad range of needs.
Yeah, I was going to add, I think for us, it was kind of a similar path where length of stay was really important because we had some obligation to the hospital for tracking those days or that time that people spent mostly interested in turning them over so other folks could come in. And then as that went away, and our program prior to COVID was shelter-based, so beds within within one of our larger shelters, and we're moving to a more freestanding respite program where we'll have dedicated rooms for respite, and it isn't considered shelter, it's considered a recuperative stay. And so I think it'll be interesting to see, like we'll be using that data to see how is it working, discharging based on the condition that resolving that brought them into respite, knowing that we won't be able to keep people long enough for them to move into permanent supportive housing or other like permanent housing opportunities. So I think we have been seeing like an average of 30 days because in our shelter-based program, people were just discharging to other areas of the shelter. And it was really easy to keep someone for 6 months if we needed to, because they were working on some things with our case managers and social workers. We won't have that luxury anymore.
Yeah, that'll be an interesting shift to see, especially if the housing market maintains itself where it is currently. I don't think anyone on this call is from somewhere where they're immune to that particular issue right now. So we just have a few minutes left here. I've gotten to ask a lot of questions, so I did want to open it up and make sure that anyone here didn't have any questions they'd like to ask of each other, just for some thoughts, advice, feedback, or even share anything about your program's outcomes at this point. So as everyone is wrapping your minds around all of this, I'm going to share another outcomes related resource that we have in the chat here. This is more sort of a baseline around understanding outcomes in respite. This was sort of our first publication. That was the result of a learning collaborative and some participating respite programs really working at this, which is really helpful in thinking about and kind of coming up with these buckets of outcomes that we look at in medical respite programs. So it's a nice resource to kind of partner with the other one I shared that dives into the details. So I'd recommend sort of reading through both of these. And as Julia is mentioning in the chat, we would love to hear from you, both in what kinds of supports would be helpful. We certainly have a couple of publications, but what else can we do to help support you all in sort of navigating the outcomes piece and maybe being like me and transitioning from outcome avoidant to outcome active, I don't know, or connecting you with folks like Lori who are really excited about it. Let us know what would be really helpful for your programs in sort of navigating these challenges. And if you have any really great resources or examples from your programs, we are always looking for those as well. So any intake or assessment tools that you found particularly useful, any processes, any ways that you report your information, if you don't mind sharing those with us, we really welcome them so that we can give people some tangible examples on that. And Julia also asked too if there are other stakeholders that we should be talking to about this outside of respite providers. And I appreciate some of the folks who did join the call today who are kind of from the funder end of it to shed some insight into what they're looking for and sort of that perspective and how we can find some real strong common ground for everybody. And I'll answer the question in the chat, and this is a good wrap up of some things that we have coming up. So we are doing a little bit of a holiday break from our Zoom meetings, but we will have an all member meeting. I believe it's on February 1st. We don't have the registration open yet, but you can do a save the date and you'll hear more from us about registering for that. And that our all member meetings are a great time to come in. Again, we sort of do some updates on what's happening with NIMARC and the council, new resources, and then generally trying to have an opportunity for a large group and small group discussion about some major issues that are happening within respite programs. We also have our national conference this year happening in May. So we have a respite pre-conference institute that will be happening. It's in Seattle or just outside of Seattle this year. And so that Respite Pre-Conference Institute is the opportunity to come together as respite providers, talk about major issues, learn from each other. So that'll be another really exciting opportunity and is moving forward in person. So it'd be nice to sort of hopefully see a lot of these faces without the computer screen in front of it coming up. So Julia or Stephen, did I miss any other exciting things that we want to share? Well, I remember, if you haven't filled out your directory form,
Yes.
Update your directory form. I'm certain many of you have gotten emails from all of us within the past week or so, but this is really helpful for our advocacy efforts. And when we have larger conversations with some of these bigger players in the field, being able to represent you well and accurately, it's really important for us to know what's happening on the ground. So the link is in the chat. Oh, I don't think I shared it. Yes, Stephen shared the link in the chat. So please, if your program hasn't submitted that yet, please do it. All right, Julia, now was that what you're gonna add?
I was just gonna add for the February all member meeting, and I'm sorry, I've got a heavily panting dog next to me. Caitlin, I think we had talked about the levels of care conversation. So I'm sure all of you are having this conversation at some time in your program just around when you get referrals for folks that are needing a higher level of care, really getting some clarity about what that actually means, what different care venues are, and potentially needing to educate some of your referring partners or community partners about those other venues, and talking about how we can continue to provide excellent respite services while also advocating for more opportunities for long-term care, assisted living support, nursing home support, skilled nursing support for people experiencing homelessness when it's really difficult to get some of our folks into those resources. So it should be a really good conversation. I think respite programs are often put in a really uncomfortable space when they get referrals of folks who are really needing a different level of care. And it's really a moral quandary when you have somebody in your program who's decompensating. So should be a good conversation in February. I hope you guys will join us.
Caitlin, I just wanted to throw this out there, and Julia, if you were on video, you'd probably shoot me daggers, but Kyle really made me start to think that if there is a way as the entity that we are, if we could expand the conversation with the MCOs, maybe in the form of a summit or even just starting something smaller, because I think hearing from them collectively and them hearing from us collectively could be very, very valuable. I don't know, just a thought. That's a lot. It's
yeah, no
big.
daggers there. I fully support that. I think it's a really good idea. Yeah, I think it's a great idea, and we'll talk about it on our team.
Yeah, and could be a way for us to help even just identify some of these more quantifiable assessment tools and make recommendations for programs as a whole to identify where to start, but also to support that reporting piece. So
I also think there's an education gap here for a lot of our health plans about what recuperative care, medical respite care is. And I think that can really be a challenge as it relates to data of what should programs be collecting, what's realistic to expect of programs, all of that. So yeah, Lori, I think it's a great suggestion.
wonderful. We love suggestions like that. So we are at the hour, so I will end us here. But as you keep having ideas, suggestions, questions, need support, please be in touch with us. We are here for you. And thank you everyone for joining this conversation today, especially to Susanna and Lori for sharing about your program's work.
Thanks, everyone.
Great, thank you.